friends, hi, this is Dr. Shonali Chandra. I welcome you all to our YouTube channel Medicine Decoded. Now friends, over the past decade or so, our understanding of how labor progresses for most of the women has undergone a dramatic shift, and it is in line with these new changes that the WHO came up with the labor care guidelines, and along with it came the WHO Next Generation Partograph. So in this video, I will give you a brief overview of how this next generation partograph is different from what we have been using so far. Now, we're all aware that the partograph is a graphical tool designed to monitor the progress of a woman during the course of labor, monitor the maternal and fetal well-being as well, in order to document them properly so that we may be able to assess the progress and maternal and fetal well-being, make a plan and decide accordingly. In the modified WHO partograph that we are using, plotting begins at 4 centimeter cervical dilatation, so that's our threshold for active phase, and there is an alert line already made on the partogram corresponding to 1 centimeter per hour rate of cervical dilatation, and exactly 4 hours beyond that there is a parallel line which is the action line. We're also plotting the contractions here half hourly, the frequency of contractions, right, so the number of contractions in 10 minutes as well as the strength of the contractions is noted by different types of shading that is we used on the boxes. However, in this modified WHO partograph, there is no space or no place for documenting the progress in the second stage of labor, that is after full dilatation of the cervix. This modified WHO partograph has been adapted and based on the seminal work by Friedman et al., who described how labor progresses in the majority of women. So they described a slow latent phase and the more rapid active phase of labor, and the threshold of cervical dilatation was about 3 to 4 centimeter. Now this progress of labor curve given by Friedman et al. Has been challenged, and now we have what we call as the new labor curve. So this is the labor curve given by Friedman et al., and this is the new labor curve here given by Zhang et al., and they are saying that the cervical dilatation is slow initially, and even between 4 to 6 centimeter the cervical dilatation is slower. Okay, and the rapid rate of cervical dilatation is achieved once the 6 centimeter threshold of cervical dilatation with significant cervical effacement has been crossed. So it is in line with these new findings that the WHO gave this next generation partograph. So why this revision? Why a next generation partograph? So what we've been seeing over the years has been an over medicalization of childbirth. We've been seeing increasing rates of cesarean sections, particularly for arrest of labor or simply non-progress of labor, and we have come to realize that labor will be different for different women, and it may not progress by the standards laid down by Friedman et al. Or by the standards laid down by the modified WHO partograph, and many women will go on to have a non-progress of labor if those previous graphs were adhered to. And now there is this consistent debate that is raging on what is normal labor progress, right? So labor progress has been now individualized. It will be different for different women. We need to understand that concept, and therefore now they are questioning the concept of alert and action lines as well. I mean, how slow is slow labor? Let's put it that ways. Now moving on, let's come on to understanding what is this WHO next generation partograph. So this is a snapshot of a complete partograph here, the graphical record here, and what is similar in comparison to the WHO modified partograph is that yes, the time is noted on the x-axis. The woman's progress in labor is determined by the change in cervical dilatation and the descent of head over a period of time. That's the same. Maternal and fetal well-being is noted over a period of time. That's the same. But something that we see head on is that there is no alert line here, there is no action line here. So we need to see how this next generation partograph is different, what's new. What's new is the definition of active phase of labor. So, active phase is defined when the contractions over time have been seen to be increasing, there is substantial degree of cervical effacement, and rapid cervical dilatation has started, and the woman is dilated to 5 centimeter onwards. So this is what is new, a threshold of 5 centimeter cervical dilatation as the active phase threshold. Then second stage labor monitoring is also intensified now. So we have areas where we are going to monitor and document the progress in the second stage of labor as well. And yes, there is no action or alert line there in the new next generation Partograph. Apart from noting the patient particulars like we did in the modified WHO Partograph as well, there is an entire column documenting the supportive care that is available to the woman during the course of labor progress. So a particular mention of whether she is accompanied or not, what pain relief is she on at all of any pain relief, whether she is taking oral fluids or not, what posture is she maintaining during the course of labor progress, is she mobile, ambulatory, or she is lying down supine. So yes, a lot of emphasis is given on effective communication and companionship and supportive care to the woman as well. So that's something new. What's also new here, you can see now the characteristics of the baby and the woman that are noted here, and we can see that the baseline fetal heart rate is documented, counted and documented in beats per minute. A column is noted about fetal heart rate decelerations, whether present or not, whether early or late or variable, amniotic fluid, just like the one in the previous modified WHO Partograph, that is also there. Noting of caput and molding is also there. What's new here, you can see, are noting the characteristics of the baby or the fetus here. So we have a documentation of the baseline fetal heart rate denoted in beats per minute, noted down to be very specific here. New is the denotation of whether or not fetal heart rate decelerations are seen, if they are early, variable or late, that is noted down. Amniotic fluid is noted, caput molding is noted just like in the previous Partograph, and new is noting of the fetal position, whether occipito-anterior, posterior or occipito-transverse position. So that's something new. If you look at the characteristics of the women that are noted during the course of labor, yes, you have to note the pulse rate, the BP, the diastolic BP, systolic BP, the temperature and urine. So that's there earlier also. But now clear-cut documentation of these records have to be noted over a period of time. And what we also see here is that alert thresholds are defined, if you have a look. And what we also note here is that the alert thresholds are defined. Like for example, L for late decelerations. So that is an alert threshold we need to be aware of. And similarly for the rest, specific alert thresholds are defined for ease of assessment. Now what else is new here? Let's have a look. So when we are noting the contractions, we are actually writing the frequency of contractions. So number of contractions in 10 minutes has to be noted. The duration of contractions has to be noted. Each contraction lasting for how many seconds, that is noted. So that is averaged out over a 10-minute period. So you have anything less than or equal to 2 contractions is an alert, and more than 5 contractions is an alert. Similarly for duration also alert thresholds are noted. The cervical dilatation is plotted similarly with an X, but the plotting begins from 5 centimeter dilatation onwards, and the descent of head is plotted by 0. And again on per abdominal examination we see how many fifths of the head is palpable above the pelvic brim, and that denotes 5/5 palpable, 4/5, 3/5, 2/5 and so on and so forth. So this is on per abdominal palpation. We plot the descent of the head here also. And what is particularly important to note here is that there is no action or alert line at all. Instead we have specific time-based thresholds at each centimeter of cervical dilatation are defined to label as non-progress or slow progress or a rest, right? So you see here in the active phase, it is written here that you plot an X to record the cervical dilatation, and the alert is triggered when the lag time for current cervical dilatation is exceeded with no progress. Like for example, if a woman has been at 5 centimeter for a duration of more than or equal to 6 hours, that would be the threshold for triggering the alert. And now if you come to this side of the graph, there is time-based plotting. We've been given 3 hours of second stage plotting here as well. So again, we are noting the contractions on the upper part of the graph. In the lower part of the graph, you have to insert P to indicate when the pushing begins. So at any point in time when the woman starts pushing, P has to be noted, and you can see here that in the second stage, descent is being plotted still. So yes, the second stage monitoring has been intensified in this next generation partograph. And overall, if you see in the bird's eye view, you'll realize that the duration of the active first stage of labor here is a time span of 12 hours, right? So usually, yes, for first time births, that is for nulliparous primigravida woman, the first stage of active stage of labor is usually not more than 12 hours, and not more than 10 hours in subsequent births. And in the second stage for first time births, yes, the duration of second stage should not exceed more than 3 hours, and for subsequent births it's 2 hours. So these changes have been incorporated in this next generation partograph. Now these are also in alignment with the new ACOG guidelines regarding the progress of labor as well. So what's new is evidence-based time limits at each centimeter of cervical dilatation and intensified monitoring during the second stage of labor as well. And what's also new here is, of course, the medication part was there in the previous partograph as well, but yes, a shared decision making, right? So the progress of labor has now been made very woman-centric, right? So at each level of care, you see here at each hour, an assessment is made whether it seems like normal progress or not, or any deviations during the course of labor, whether it's about progress or maternal or fetal well-being, has to be highlighted and noted down, and a plan has to be made. If a midwife is following this partograph, the senior faculty or the senior person in charge has to be incorporated and involved in the shared decision making, and a plan has to be made and stuck to and adhered to during the course of progress of labor. So this is how the next generation partograph is different from what we have been using so far, which is the modified WHO partograph. To give you an example how this can be clinically made useful and used, let's take up a scenario of Mrs. S, a low-risk pregnant woman, primigravida, nulliparous, so it's a first labor at 40 weeks, and she's admitted to the labor room with contractions. There is no complaint of bleeding or leaking from the vagina. Her pregnancy so far has been uncomplicated. So yes, relevant history, detailed history workup has been done, and after that, yes, an initial clinical examination is also done, which involves general examination, a per abdominal, and a PV examination as well. So a pulse rate is 88 per minute, blood pressure is normal, temperature is normal. She is passed urine at the time of admission, and the urine has been checked with a dipstick. There's no proteinuria, there is no acetone, let's say. And on per abdominal examination, the uterus is term sized, cephalic presentation, head is 3/5 palpable above the pelvic brim. She's getting regular contractions. See, we're noting 3 in 10 minutes, lasting for 35 seconds of moderate intensity. The fetal heart is noted, 140 beats per minute with no decelerations as of now. So an initial workup and initial examination has been completed. This on per vaginal examination, the cervix is found to be 5 centimeter dilated. So yes, the partogram plotting for this woman can begin now. It's 80% effaced, so there is some significant degree of effacement. Bulging bag of membranes has been felt. So yes, the new labor care guidelines mention that there has to be a significant degree of effacement. They've not specified the exact amount of effacement that is required, but they do mention significant degree. And this woman that we have examined, she's unaccompanied at present. She has taken fruit juice, is walking, and requests for pain relief. So yes, we are also incorporating supportive care as well. So now let's have a look at how this can be incorporated and plotted on the Partograph. So this is Mrs. S. It's a first, labor. She's a primigravida. There's no prior birth, so parity 0. She's in spontaneous labor, and she's been seen at, let's say, 15th of October, 2 p.m. That is when we decided that the platogram needs to begin. There are no risk factors identified in history. The membranes have not been ruptured as of yet. There's no leaking. There's no bleeding. So yes, these patient particulars are noted down. Once we are done with the complete examination and history taking, we start plotting the partogram here. So at 2 p.m. that was when her assessment began. She at that time did not have a companion, so no. Pain relief is not ongoing at present, so no. She's requesting for it. However, she's taking oral fluids, yes, and she's walking. She's ambulatory, she's mobile, so MO, so she's not lying down in supine positions. So this is the first section of the graph that will be completed. Now moving on, next we are going to put in the baby characteristics and the woman characteristics in place as well. So let's, at the time of assessment at 2 p.m., the baseline fetal heart rate was 140 beats per minute. There are no decelerations, right? The amniotic fluid is not leaking at present, so the membranes are intact. We do not have any information about the fetal position as of yet, so that can be left. No information about the catheter molding, that has not been given, so not felt, so that can be put in as negative. Woman's pulse is noted at 88 per minute. The systolic BP was 120, the diastolic BP was 80, the temperature was normal, it was 36.5 degrees Celsius, and there was no proteinuria or acetonuria as well. So this section of the graph is then completed. And moving on, let's also note down the other characteristics and fill the other section of the graph. So here at 2 p.m. at initial assessment, she's getting 3 contractions in 10 minutes. The duration of contractions averaged out is about 35 seconds, so that's noted, and she's 5 centimeters dilated at 2 p.m. and the head is 3/5 palpable above the pelvic brim here, so that's denoted as 0. So this is how we are beginning to plot. And if you look here about the next part of the graph at 2 p.m. at that point in time, she's not getting any medicine, any oxytocin or any IV fluids. The assessment at this time is that she has gone into active labor, so active labor has begun, and the assessment is that she needs pain relief and she needs companion. So that is the plan. So the plan is arrange for a companion, let's say. Yeah, she's requesting for that. A relative can be called, right? And pain relief, arrange for companion and pain relief. That's the plan so far, and these are the initials which are going to be noted. So this is how it helps in monitoring, documenting and assessing and making a plan accordingly. Now moving forward, yes, at the end of it all, I will decide when should be the time for the next assessment, right? So I feel that as long as a progress over time, over a period of time is going to be fine, I can do a repeat pelvic examination after 4 hours. So no intervention will be done until and unless medically indicated, right? So we're not going to unnecessarily intervene during the course of a normal progress of labor. And the monitoring of other parameters, like the monitoring of fetal heart rate every half hourly or the monitoring of uterine contractions every half hourly, that is going to continue as usual. So over the course of monitoring, we see that the companion is now arranged, she's getting the pain relief, she's taking oral fluids in between, she's maintaining posture as mobile, that means she's walking around, she's shifting her posture, she's not supine basically, right? And then at 6 p.m. assessment, she's now lying down supine, so that needs to be highlighted and circled, so that's our alert here. And then moving on, we see that the baseline fetal heart rate has been consistently fine, no alert raised. There are no fetal heart rate deceleration, so absent, so no alert raised. The membranes have been intact, but at 6 p.m. she probably must have complained of leaking, and the amniotic fluid is clear, so that is also not an alert, so that need not be circled. Then the fetal position is occipito-anterior, let's say, so that's fine, no alert raised here. There's no caput, no molding. Pulse rate, systolic BP, diastolic BP, maternal characteristics, they've been repeated after 4 hours, they've been fine. So everything has been consistently okay, showing normal parameters. If you look at the contractions over time, so she's been consistently getting increasing contractions with increasing duration, right? So earlier 35 seconds, then 40, then 45, then 50-second duration contractions. In the next generation Partograph, the strength of the contractions is not noted, and since the progress and the contractions were fine and there was no maternal indication as such to do a PV earlier, so there was no indication to do an early pelvic assessment, so that is why pelvic assessment was done at 6 p.m. after 4 hours. So 4-hourly pelvic assessment and PV findings to be repeated until unless indicated, right? So let's say at 6 p.m. she is 10 centimeter dilated, so X is marked here. Let's say at 6 p.m. the head is only 0.5 palpable above the pelvic brim, means no head is palpable above the pelvic brim, so the 0 for descent will be marked here. And let's see what the plotting has been over the course of time, in the middle. So we can see here that each time the midwife has probably noted normal progress, and continue monitoring, and normal progress and continue monitoring, right? So at each step, assessment and then plan is noted down, and whenever an alert is raised, a senior person and needs to be involved in the shared decision making process. So once she is fully dilated, then we have to take care of the monitoring in the second stage of labor. So in the second stage of labor, again we are monitoring the fetal heart rate as well. So in the second stage now, we are monitoring the fetal heart rate every 5 minutes. Yes, so in the first stage of labor, we are monitoring the fetal heart rate every half hourly, and in the second stage of labor, we are monitoring every 5 minutes, and we are noting down here the most significant fetal heart rate over a 15-minute duration. So that is what we are noting down here, right? We are also noting down the other characteristics as well in the second stage of labor, and we are also noting down now, let's say for example at 6:30 p.m. she got the urge to push and bear down. So yes, pushing has to be noted here, and the contractions have to be noted, and the duration have to be noted every 15 minutes. So intensified monitoring of the second stage of labor is done, right? And the descent is what we continue to plot even in the second stage of labor, right? And you realize that the alert that will be raised here will be according to this time duration. Let's say 3 hours gone by and yet not delivered. Now let's see, for this woman, probably she may have delivered. Let's say everything was fine here, she was pushing, and let's say at 7:30 p.m. within an hour of pushing, let's say she gave birth and delivered. So that will be the completion of our partogram ultimately, right? So this is how this next generation partogram, briefly I have discussed with you how it can be used, and at various steps alerts are going to be raised based on the defined thresholds. Now let's just take an example of that as well. Let's say a midwife was using this partograph, and let's say at 6 p.m. The dilatation was not at 10 centimeter, rather at 5 centimeter only. So she realized here, she assessed something, right? And then let's say, for example, the assessment that she made was this is nearing the threshold, right? She assessed that this is nearing the threshold of 6 hours. It's been 4 hours that she's been at 5 centimeters. So she decides that, let's say, the next assessment can be done at 2 hours later only, right? Instead of delaying the pelvic assessment or PV examination for another 4 hours, let's say she decides to do it at 8 p.m. let's say, and let's say at 8 p.m. she was still 5 centimeter, then she would have raised the alert flag here, highlighted it, right, and then assessed it to be at, let's say, 8 p.m. assessed it to be a rest at 5 centimeter, and then she would have liked to, yes, made a plan to inform the senior to come and review the case as to why there is a rest at 5 centimeter. Is there a need for oxytocin augmentation? So a decision and plan need to be made. A shared decision making needs to be done. Or is there any other factor? Is there any evidence of cephalopelvic disproportion, right? So an entire graphical record of the patient's progress as well as maternal and fetal well-being during the course of labor is monitored, documented. Specific alert thresholds are predefined. There is no alert line, there is no action line, there are alert thresholds that are defined. At each time, you see, the assessment has to be made, the alert points need to be identified and communicated to the obstetric team, and a final plan for the woman needs to be made, which is a part of the shared decision making protocol. Now this is how the next generation partogram is different than what we've been using, that is the WHO modified partograph. Now yes, my friends, some of you are preparing for the NEET PG and various postgraduate entrance examinations. So if you recall from what you have seen in your labor rooms being used by your nurses, by your seniors, is the WHO modified partograph that you should be aware of. However, you should also know that there is a next generation partograph. There is a need for revision. What are those revision points, and how is this next generation partograph different from what we have been using and still continue to do so? So you need to be aware of this recent change. For those of you who are actually practicing in labor rooms, who are day in and day out monitoring laboring patients, it's a good idea to start incorporating these changes, if not this partogram, at least the understanding of this partogram, what it implies in taking care of a laboring woman. That is what I want to drive through from this video. I hope you find it useful. Thank you.